Welcome back, guys. So in this part of our lecture, we're going to talk about some of those other obstructive defects. The first one we'll talk about is asthma, which is, again, often thrown into the family of COPD because it is an obstructive defect and it is a chronically occurring defect. However, unlike emphysema, unlike alpha-1 antitrypsin deficiency, unlike chronic bronchitis, asthma has a reversible bronchospasm, right? So remember that those flow defects we saw on either the volume time curve, which we saw, reductions. Patients with asthma, if we give them a puff of an inhaler, their obstructive defect gets improved. And it's often characterized by reduction in peak expiratory flow rate. So we look at that flow volume curve in these patients. So again, it's a reversible bronchoconstriction. It manifests also much earlier in life. Again, we said COPD. That's something that occurs much later in life, even with alpha-1 antitrypsin deficiency. At the earliest 30s, they start having symptoms. Patients with asthma get symptoms, in childhood. I myself have asthma, and I was diagnosed, I believe, at 5 years old with it. So it's just a little bit different than COPD. Again, it's that because the symptoms are reversible. It's a different mediator. Often we think it's just due to these hyperreactive airways, overexpression of those mast cells. Remember that from the physiology lecture, which secrete those leukotrienes and histamines. Leukotrienes especially are involved in asthma due to their bronchoconstrictive effects. That's why a lot of medications for patients with asthma go after those leukotrienes. There can be multiple different triggers to this. We think, one, it could be just different particulate in the air. And we think there's, a lot of different things that may be associated with causing asthma. We think, chronic inflammation can be a role in there, as well as childhood exposure to smoking can set them up for asthma, as well as obesity. And that obesity may, also has inflammatory processes. Remember adipokines and all that. But obesity, their exposure to obesity may explain why we've seen a much higher number of asthmatics now. There are 22 million people in the United States who suffer from asthma, who have asthma, and that's an increase up from 15 million a decade ago. So we're seeing more and more, but that also, we are seeing more and more obese people. I actually think there may be other conditions kind of going on there in these obese people with dyspnea, and we'll talk more about that later. But asthma, again, a fairly common condition. The symptoms, again, are this wheezing, dyspnea. They may even have a little bit of chest pain, especially if the lungs get irritated and inflamed and constricted. We've got this classic picture here from Netter, just kind of grasping at their chest. If anyone who's ever had an asthma attack, it feels like your chest is kind of burning. That's the feeling they often report. I can speak to it myself. And then obviously facial distress. Like this classic picture here from Netter, especially when they're under an asthma attack. Now, they often have a non-productive cough, not a lot of mucus, where the mucus is usually kind of stringy. But there can be, depending on what the trigger is, if it's an infection, there's obviously going to be some mucus there. Remembering, again, it's the mast cells and other things are kind of involved here. Now, there are several varieties of asthma. Okay, one of the more common subgroupings is exercise-induced asthma, EIA. This is actually the variant that I have. So exercise-induced asthma is these symptoms, is bronchoconstriction or significant reduction in the post-expiratory flow rate, even occurring well past the cessation of exercise. So they get their asthma symptoms during exercise. Why that happens, we're not exactly certain. We think that the exercise-induced asthma may be due to a loss of water and heat from the lower respiratory system due to mouth breathing. So if you don't breathe through your mouth, you bypass these nasal passages, which kind of warm and humidify the air, remembering our normal physiology. So because of that loss of heat and water and moisturizing, We see hyperemia in the lungs, vascular engorgement, which lead to bronchial edema and potentially reduction in the lumen size. Now, whether that is the exact reason, we're not exactly certain. We may think it be maybe some of the hypersensitivity, just in general, maybe exercise is a trigger for it. But again, there are a subgroup of populations where exercise is their stimulus for having these asthma symptoms. Now, if it's severe, right, and persistent, there's a condition called status asthmaticus. So that's someone who has a severe asthma attack. It's so severe that it's even causing cyanosis. Like their airways are just they're super inflamed. They can't get any air in or out, and they start to turn blue. That's a medical emergency. So that's someone having a very, very severe asthma attack. Now, we'll get into some of our septic obstructive disease. Again, these are obstructive defects, but it's really more due to this excessive production of mucus or purulent sputum and high risk of infection. So the first condition we'll touch on is bronchiectasis. So bronchiectasis is a term for an irreversible airway dilation due to destruction of the muscular and elastic properties of the lung, right? So 70% of these causes are due to another cause. So like, COPD or cystic fibrosis, which we'll talk about in a little bit. But 30% sometimes can be due to an idiopathic cause. Like we don't really know what's going on. And again, what we end up seeing in our normal kind of nice looking airway here, or bronchiole, right? In these patients, we move from a clear, nice, round, and well-supported airway wall to a destroyed and thickened and scarred and weakened airway filled with mucus. So they're easily collapsed, they're plugged and filled with mucus, very inefficient ventilation, and very tired work of breathing. Bronchiectasis can be focalized to one area of the lung with extrinsic causes, so it could be a compression maybe from a tumor or a mass. There can be intrinsic causes, like we mentioned, aspiration or bronchial atresia, or lack of formation, or scarring and stenosis. Again, a lot of this is due to other conditions. Or there can be diffuse changes, right? So, widespread, pulmonary condition like CF or COPD leading to bronchiectasis. These patients will have, a persistent cough with, thick, tenacious, so it's purulent, thick sputum, crackles and wheezing on auscultation due to these flimsy and inflamed and broken down airways and mucus plugging. And they'll have an obstructive pattern because the airway walls are just broken down and scarred. They're flimsy and they're widened. And then, of course, there's cystic fibrosis, which is, again, the number one genetic pulmonary disease in kids. Cystic fibrosis is a disorder in the cystic fibrosis transmembrane conductase regulator, which results in a multi-system disease. I think we often think of cystic fibrosis just as a lung disease. It is not just a lung disease. When we affect the sodium-potassium channels, produce this salty mucus formation and the sodium-potassium channels in other cells, it affects everywhere. The lungs obviously are the big concern here, but we see changes in the pancreas, we see changes in the liver, we see changes in the sweat ducts, we see changes in the GI tract, in the reproduction system. Quite often patients with cystic fibrosis develop type 1 diabetes, they develop bowel obstructions quite often because of the excessive mucus production. They often have, in men, infertility. So it's a multi-system disease. We also see a very high prevalence of pulmonary artery hypertension. Now, whether that's due to the lung disease or some of the fibrolytic changes that occur concomitantly in these conditions, but we see a very similar, we see pulmonary arterial hypertension in these patients. And in fact, their ventilatory responses to exercise are almost very similar to patients with pulmonary hypertension as well. So we see obstruction of the small airways, destruction of the small airways, bronchiectasis. Again, we said bronchiectasis is it can be quite often due to an underlying condition like CF 70% of cases. So bronchiectasis can develop a diffuse pattern in cystic fibrosis. Fortunately, we catch this early Most patients are diagnosed 75% or more before 2 years of age. And that's done by using a sweat chloride test. These patients often have a very salty tasting skin just because of the excessive kind of salt production. They'll often report symptoms of wheezing, coughing, often frequent kind of bulky stools. They'll often be very underweight or malnourished because of the impaired absorption, because their pancreas isn't functioning well, their GI tract isn't functioning well. So they are typically a little bit frailer, a little bit smaller, because again, cystic fibrosis, it absolutely affects the lungs, but it is a multi-system disease. It has very significant metabolic and even vascular complications. Again, the pulmonary artery is quite affected as well. And the life expectancy for CF has gotten much better. Again, we were able to detect it a little bit earlier, and the thing that ends up killing most kids with CF are these frequent infections. They have a high risk for developing pneumonias, a high risk, for any kind of opportunistic infection. One, because their lungs are filled with this, thick, purulent sputum that requires very consistent airway clearance. And they are also just, if you want to think of it, malnourished. Like they have issues with absorption or malabsorption. They don't absorb food super well, so they're just not as robust, right? So a lot of attention has been placed on airway clearance. It's critical for these kids to keep up with airway clearance. We'll talk about some of those techniques later on. Exercise, they got to keep themselves healthy, and exercise is great for airway clearance. Just moving around is great for your lungs. And nutritional supplementation, taking protein shakes, similar to our patients with COPD. If it's hard for you to breathe at rest, it's going to be hard for you to have periods of apnea that you need for eating. And for CF especially, they have just this thickening, these GI disturbances due to this mucus production and the changes of the pancreas. So nutritional supplementation is huge for these patients. Years ago, patients with CF didn't really live past 20. Now, for people who were born in 2018, 50%, right? The median is expected to live to about 47. That is remarkable. Absolutely remarkable. And we stage the severity, the prognosis by their FEV1s. Again, the biggest thing for them is to stay compliant with airway clearance and, exercise. Important to note, I didn't mention this on the previous slide, there are potentially 1,700 known mutations of this gene, right? So we're learning that there may be even more variants of CF than we may realize, and some patients who have symptoms of respiratory disease may actually be CF. So again, it's very different. I had a close colleague of mine who has CF. She is an amazing PT and scholar, and she did cross-country skiing. She's very healthy. Again, there's different variants, so just be aware of that. So with that, we'll take a little bit of break, and then we'll get into some restrictive lung diseases. Thank you.